Thank you. Thank you, Professor Zhao. It's great to be in this session, to see many experts and colleagues that I know and respect a lot, and also meet new people both online and offline. As you can see today, I will talk about improving secondary prevention of cardiovascular diseases in rural China through implementation research. You have heard about the great talk by Professor Prabhakaran. He covered quite a few different areas, and it's really comprehensive. But today, my focus is on rural China and secondary prevention. So I will talk briefly about the gap and the reality and introduce three studies very quickly, all of them in rural China. As you might notice, SIM card appeared in one of Dr. Purapaka's slide as well as the example for a primary care-based intervention because this study was done in both China and India, but today I will talk about the China part, all three studies in China. So there is a big gap between scientific evidence or clinical guidelines for cardiovascular diseases and the health services patients receive and what happens in the real world in actual practices. So this is the science and practice gap. More widely, it can be known as the know and do gap, which is a common problem for us as individuals too. So as a health researcher, the one research method, it used to be called translational research, but nowadays more called implementation science. They are not exactly the same, but roughly we can ignore that difference for today. Is one way, is one kind of research that is addressing this gap. This is a slide based on the NIH depiction of the different translation needed from basic science to clinical research T1, from clinical research to population research T2, and from population research to policy and practice. What my research team does focuses on T2 and T3. And very briefly, this is a summary of based on clinical guidelines for secondary prevention, covering medication, risk factor control, and lifestyle modification. But we know there is a big gap between the guidelines and the reality. And this is based on the PURE study led by Professor Youssef. And it has data from 17 countries, both the high income countries and upper middle and lower middle and low income. This is overall. And you can see this is blue is one drug, and this is two drugs, this is three drugs, and the gray one is no drug. So according to the guideline and the data we know, for people with cardiovascular diseases, about 80% or more should be on drugs. And for the upper middle and lower middle and low income countries in particular, about 80% not on drugs. So there is a huge gap. And the reality in China, I just use this older slide because this is data from 2008, which is the year before we started our first study in 2009. And you can see for both urban and rural cardiovascular diseases, the red one is stroke and the light pink is heart disease. Together, they consist of the largest disease burden. They are about 40% of all deaths were from cardiovascular diseases, and it's not just a problem for urban areas, as some people may have thought is a wealthy disease. That's not the case. You can see the burden in rural China, especially stroke, was actually even higher. And the trend was that urban areas overtook rural areas overtook urban areas in the disease burden. So we did this baseline survey in 2010 among older adults, and older adults was defined as over 50 for men, over 60 for women. And you can see that whether they are at high risk of having the cardiovascular diseases, older age, and having diabetes, or having a blood pressure, systolic blood pressure of over 160, or having those diseases already, altogether is 1/3 of older adults. This is highly prevalent. And I want to mention that because we included people at high risk and not having the diseases yet, so our study included both secondary prevention and primary prevention, because I think the distinction isn't important, but having cost-effective strategies to reduce their disease burden and the risks would be the most important. So this is some pictures from one of the field trip. You can see this is the village clinic for one of the villages we work in, and they're building a new one. But at that time in 2011, it was not done. So the real challenge in rural China is that there is a very large number, estimated to be 1/3 of older adults, who are left behind by their children, many of them working, migrated to cities to work. So they're left behind in the villages without access to essential, high-quality, evidence-based treatment. So we believe community-based primary care can offer a practical solution. You can see this photo was taken years ago, and at that time, village doctors focused more on maternal and child health and vaccination, etc., infectious diseases too. And China has really led the way and provided examples for other countries in terms of improving maternal and child health outcomes through these strategies. So our study extended this approach to cover cardiovascular disease management in rural China. So in this China Rural Health Initiative, we had the standardized management for high-risk patients, which was much simplified based on clinical guidelines, which is very complex for primary care. There are primary care guidelines which were still too complicated for the village doctors who are the primary care providers in rural China. So we had the simplified, standardized management. We trained them to screen, manage, and follow up the high-risk patients and refer them if possible. I don't have time to go over the details of the management, but just to say that is evidence-based, and we took nearly a year to pilot it, to customize it for the village doctor situation. And we also provide performance-based feedback for the village doctors so that they know how well they're doing, and we provide benchmark against the other village doctors in the same county and for the overall study. And we provide incentives distributed by the government to motivate them to work better. So we have a cluster randomized controlled trial because the intervention was conducted at the village level. And you can see we had 5 provinces, all in northern China, where the burden of cardiovascular diseases is higher than southern China. And we had 2 counties from each province, 10 townships from each county. So 12 townships from each county. So altogether 120 townships. We chose only 1 village in this study from each township, which had an average of about 15 villages, so that there would be reduced contamination, as the village doctors in a single township are managed together by the township healthcare center. So for the 120 villages, they're randomized into equal number, 60 intervention, 60 control. And to show this in a nutshell, we show the clinical care outcomes, and the blue are for intervention, the orange for control. The lighter colors are the baseline, and the darker colors were the difference. So you can see, compared to the control, there were significant increases in regular primary care measured by monthly primary care and lifestyle modification advices and receiving the drugs and for blood pressure drugs or aspirin. So based on these experiences, we want to take it further to not just northern villages, but also in India, in the state of Haryana, and also Tibet Autonomous Region in China. We further simplified it beyond what we have done in northern China. So we called it SIM card. And you can see from this flow chart, it's also a
看到这
class
是我们的工作
randomized
流
trial.
程
We had a
这是在
total
进
of
行了
27
随机
villages
化
in
的这样一
China,
个实验的分组之后，
20 villages in
我
India,
们看到总共是有
altogether over 2,000 participants. And the intervention was both simplified to include 2 lifestyle modifications only, plus 2 types of medications, but also using the enablement from mobile health technology, because village doctors were able to use smartphone. So they received the electronic decision support system for them to better carry out their intervention. This is a photo of we're conducting patient briefing sessions on sodium reduction and smoking cessation. So just very quickly jumping over a lot of details, show the results. And here is the evidence-based medicine use as reported by the patient. So it measures adherence. On this panel is antihypertensive. You can see compared to baseline, intervention had a much larger increase compared to the control, which also increased. The situation for aspirin was opposite. The control group had a small reduction, but we had the significant increase for aspirin. And for China, our intervention at baseline was conducted in the winter, and we had a 1.5-year follow-up. So the follow-up was in the summer. So there was a large reduction by season of the control group, but we had about 4 millimeter mercury net reduction from the intervention. This also shows why the seasonal influence and also a randomized control trial design is important. So we published the design and the study as well as the qualitative intervention. Qualitative process evaluation results. I just want to quickly mention the third study that was building on the first 2 studies in several regards, both in terms of integrating the system from tertiary to secondary to primary, and also further development in mobile health technology. And this study focused on stroke, and we designed our study very quickly. You can see it. On the right-hand side is our model's way of addressing the barriers at village level, stroke survivor, patient level, and higher level barriers. Originally, we designed our study to include both medical care for the patients, like what we've done before, as well as rehabilitation. As you know, stroke is a highly debilitating condition. Many people were disabled. However, through our year-long preparatory contextual research, we find that's too complicated. So in the end, we focused on only one county, 50 villages, but focusing on the medical care only, and we did the rehabilitation through another trial. So in this cluster randomized control trial, we had about 25 patients per village, and that altogether, 1,200 people, close to 1,300 people were powered to estimate outcome from systolic blood pressure. So as you can see here, only on medication, not only on medication, but focusing on only the medical and lifestyle part for the stroke patients. The village doctors are at the center of the whole intervention. They receive free training and the support from county hospitals and tertiary specialists. And they had the Cinema app, which had a lot more function and very user-friendly for the village doctors, smartphone-based, and that can automatically send out voice messages to patients if they agree to receive those messages. And so this is the whole intervention in a nutshell. For the village doctors, they receive training, they do the monthly follow-up, but we also created WeChat group as a way of supporting them and encouraging them. They also received incentives. this is the functions that our APP can do. But as I said, there is a user-centered design, and the interface looked a bit like, or pretty much like WeChat. So it's easy to use, but the back end is pretty strong. And for the stroke patients, we do a briefing only one time to remind them about the study, and they receive the monthly follow-up, also with some very practical tools to help them, and they receive the village on a daily basis. The voice message on a daily basis. We did our work to find that most of them either could not read, so over 2/3 couldn't read, or they prefer not to see the text message because of their eyesight and other problem. So we send the voice messages that's recorded according to their local dialect. And the algorithm is that we send them out the message daily. And we always start the message with the question, have you taken your medicine today? Or do you remember to do physical activities? Focusing on the messages in these two aspects, but have some additional information as well, and very practical tips. So the main result we could see that in the adjusted analyses, the systolic blood pressure reduction was not too big, less than 3 millimeter mercury, 2.88. And for diastolic, we had a fairly large reduction of 2.23. As you know, for such a reduction for diastolic, it's pretty significant. And exploratory outcomes based on small sample size showed very high and significant relative reductions in stroke recurrence, the modified Rankin scale, hospitalization, and mortality. We did this study completed in 2019, but we did follow-up study over the COVID-19 period in last year and this year. So we had preliminary results for the 5-year follow-up, which showed very significant reduction in mortality. And this is still not published yet. Of note, we did not continue our intervention after 2019. So this showed long-term effect. So I would like to skip over the methodological slide and just end with this 5S principle. So we did implementation research, which is not easy to do. We learned to keep it simple. So this one is keep it simple. Keep it simple, stupid, because we often were silly and stupid in making things too complex. And the process needs to be slimmed, not complicated. And we hope to embed these approaches in the existing system, but that hasn't been progressed too well. And the longer term goal is to be scalable in space through policy support and sustainable over time with strong leadership. So there's a lot of collaborations, and I acknowledge the partial list of our collaborators, and these are the institutional supporters and partners of our studies, and some references of our publications. So thank you so much. I think I have 1.5 minutes left with my time slot, and happy to answer questions.